Hi, I'm Dr. Stan Steindl. Welcome back to Compassion in a T-shirt, where we explore the science and practice of compassion and how it can transform lives. Today I'm thrilled to introduce my guest, Professor Shane Sinclair. Shane is an internationally recognised researcher in the area of compassion in healthcare. He's professor in the Faculty of Nursing and Adjunct Professor in the Cumming School of Medicine, University of Calgary. His journey into compassion research is deeply personal, inspired by witnessing firsthand the powerful effect of taking a compassionate approach for those who are facing serious illness, both in terms of the lives of patients and their families. Shane leads the Compassion Research Lab at the University of Calgary, where a dedicated team and partners from around the world work towards improving compassion in healthcare through rigorous research, evidence-based resources, and expert consulting. From humble beginnings, the Compassion Research Lab has grown into something of a powerhouse of innovation and impact, always focused on the ultimate goal, improving lives through compassionate action. Get ready for an enlightening conversation as we dive into the world of compassion in healthcare. And so I bring you Professor Shane Sinclair. Professor Shane Sinclair, welcome to Compassion in a T-shirt.
Thanks for having me. Nice to meet you.
Your research on compassion was I think directly informed by your own clinical experience. So I wondered if we could start there. Was there a pivotal moment, or were there sort of experiences that happened that kind of inspired you to focus on compassion? I guess compassion in healthcare, really, and then eventually the foundation of the Compassion Research Lab.
Yeah, so I think there's probably a few individuals that come to mind over my clinical kind of practice. And just by way of background, my clinical practice is actually that of a spiritual health practitioner, or what formerly has been called a chaplain, but in a very non-denominational, multi-faith, person-centered kind of way. So that's where a lot of my inspiration came from, was sitting at the bedside with people in oncology settings, so cancer patients, but also I worked in palliative care, as well as other areas within the healthcare system. And so my the story that I always tell is when I was visiting this lady one day. I remember vividly, it was very early in my career. I like to think I still look young now, but I look very young back then, like sort of like bring your kid to work week was sort of the question I would get asked every once in a while, literally. So I was feeling sort of young, um, probably fairly inadequate, and was kind of a month into my initial job. And I was visiting a lady who I'll call Jade. I remember vividly, she was a 42-year-old woman with incurable breast cancer. And so she was admitted due to pain and symptom issues. She was around 45 years old, I think had 2 kids at home, if I remember right. And I was there at the bedside, sort of providing emotional support to her in terms of coming to terms, if that's even possible, or at least helping her in this process. And I remember vividly, it was in the afternoon, and in walked a nurse while I was visiting this patient. And she smiled at her from the foot of the bed, kind of looked her in the eye, gave sort of a nod of acknowledgement, recognized her, who she was, and then proceeded to go around the other side of the bed to change the IV bag that was empty. I continued to visit with Jade for a few minutes, and the nurse finished what she needed to do, reprogrammed the machine, kind of was leaving, again, turned at the foot of the bedside, looked at Jade in the eye, smiled, and again, left the room without saying a single word. And when she left, Jade confided to me in a whisper. She said, "I love that nurse." And I was a little bit perplexed, and to be honest with you, probably a little bit miffed, because there was, no love for, the spiritual care provider that was working hard,
Ah,
busting his butt,
mm,
providing care in that respect. And so I asked her, I said, like, can you help me to understand why do you love that nurse? I mean, she came in, she kind of did a routine task, smiled, had some eye contact, but then left without saying a single word. And I'll always remember what Jade told me. She said, because I can tell by the way that she looks at me that she genuinely cares for me.
mm,
So I became interested, not only in that particular context, but in other contexts where patients would tell me about, having the most amazing physician. And I would ask them sort of why, what's behind that? And it was rarely kind of, they're just really skilled with a scalpel. They're precise. Like those things are hugely, hugely important. Don't get me wrong, especially when they
yes.
go wrong. But it inevitably seemed to boil down to elements or facets of compassion, the presence of that individual, the way that they were able to understand and resonate with that person, and actions and behaviors that patients and family members felt were inherently compassionate. So that kind of, in a nutshell, I think provides the best example of how I sort of was propelled down this path and have now sort of developed a sort of a full-blown disorder or, perseveration disorder around a single term for the last 10 years that I've been fixated on and I'm very passionate about.
Yes. I mean, kudos to you really at such a young age, kind of working at the coalface. That's really kind of very moving stuff. And I could feel it, in my own body listening to you describe that situation for that woman and very young and all she was
Mhm.
facing. And no doubt you were doing very helpful work as well. But wasn't it interesting to this the briefest of moments from that nurse, and yet something powerful was exchanged, the human connection piece of it, and the non-verbals really, even it
Yeah.
wasn't that she said anything.
Yeah.
It was in her facial expression, it was in the eye contact, it was in the soft smile, and it was in the very intentional kind of doing of that. She would
Yeah.
stop and do this brief moment, go about the task, and then kind of sort of sandwiching that very mundane task between these two moments of human connection.
Yeah. And I think that's exactly what patients have told us is like in terms of how they can tell healthcare providers as being compassionate, there's kind of a whole gamut of things that they've told us. But two of the things that come to mind is sort of this idea of doing small acts, with great kindness, and also kind of going above and beyond the call of duty as really being perhaps the markers of that separate good care from what I'll call compassionate care. And again, it's the challenge is, it's not about sort of sticking some sort of instrument in between those two individuals and seeing like, is there something in the air here or something, going on here? It's much more challenging to kind of get at. But again, there seems to be something that is being transmitted, felt, experienced in those spaces that patients as well as healthcare providers have been pretty clear. Like I can I can tangibly tell, however I'm able to do that. So I think the other thing to bear in mind as well is the part of the story that's missing there is maybe all of the interactions that that nurse had had with that person previously. So, it probably wasn't the first time that they had met. She probably did converse with this person before. So, I think we have to be a little bit careful that it's not just kind of the magic of that moment per se, but obviously there is something that is deeply felt, perhaps by both parties, in terms of that interchange.
Hmm. Yeah, I imagine sort of moments matter, but a string of moments is sort of, starts to really kind of create a feeling of care and warmth. I refer to myself as a one-trick pony with compassion, but your idea of perseveration is funny as
I,
well.
I might be just a one-trick donkey. I don't know, but
Oh,
we won't use any other synonyms related to that animal.
no, but it's borne fruit for you. I mean, that's the where I was coming to. I mean, you've set up the Compassion Research Lab, and obviously that's now been, I think, a decade or more or something like that, or you've been working in
Yeah.
this area certainly for a long time now. Can you tell us about how that kind of that more personal or professional experience and the curiosity that really the seeds that were planted there have turned into this compassion lab, and what's that all about?
Yeah, so I think I need to give credit where credit is due. So I had a wonderful postdoctoral supervisor whose work was again on one word. It was dignity, specifically dignity at the end of life, and that's a psychiatrist by the name of Dr. Harvey Chachanoff. And so I think, like all things, we and what I've learned from this particular field is. Um, there are new ideas, certainly, but they're often built on old foundations in terms of wisdom traditions and contemplative practices, for example. But I think the same is true of kind of borrowing from Dr. Chachanov's sort of program of research, in which, again, he developed a model. We've developed a compassion model first. Went to patients, healthcare providers to sort of validate that, developed a measure, then moved on to interventions. And so, like I said, I would be remiss not to kind of give credit where credit is due, of sort of looking over his shoulder and thinking, how can I sort of make a run at this in a real meaningful and, I think, pragmatic way, but also in a way that's scientifically robust. And so I just sort of started plunkering away at that. And so early on in the lab, we it was basically just me, and a research coordinator and a couple of students, and we just started combing the literature, doing scoping reviews on not only compassion but systematic reviews on self-compassion and compassion fatigue, to sort of just figure out what is this thing that we're looking at? And then again, doing some original research, actually talking to patients to figure out um, how do you know when compassion shows up? Like, how do you know when compassion comes through your door? What are the sort of attitudes, but the behaviors and the skills of a compassionate healthcare provider? Um, and then we developed a measure, and as I mentioned, we're now sort of embarking on this educational intervention that we've coined, at least at this stage, ENACT. So that's how sort of it started. It started small, almost in my garage, if you will, and now it's kind of taken off to a point that I never would have anticipated in terms of not only trainees and postdoctoral fellows and doctoral students, but just international collaborators who I have the privilege of not only working with, but learning from. So, yeah, so that's kind of how we began, and we sort of pride ourselves on sort of advancing the art and science of compassion, because we kind of want to honor that there is that human element. We don't want to sort of dumb it down and strip it away from its magic and meaning. But at the same time, we want to make sure we're applying the best research that we can to really delineate it from other sort of aspects of care, sympathy and empathy, for example,
Mm,
and do the best job that we can to really make sure that these interventions are designed and able to sustain themselves.
mm. Yeah, we really are part of the great conversation, aren't we, in a way, in especially in research and building models and sort of trying to deliver interventions. We come on the shoulders of giants, as they say, the sort of the wisdom traditions, kind of more historically, but even those who just immediately came before our kind of supervisors and mentors. And it's really such a privilege to be just part of that ongoing conversation. People will
Mhm.
come after us as well. But I really like the sequence you described there. I think you sort of said you began with just sort of digesting all of the research and trying to gradually come up with something, well, an empirical model of compassion. I wonder if we could start there. What's your Yeah. What's your empirical model of compassion? What does that involve?
Yeah, so I mean, we have an illustration that sort of depicts it, but it
Ah,
came from what now amounts to, I mean, well over probably 1,000 patient interviews, as well as healthcare provider interviews, as well as family member interviews, um, to sort of, I don't know what the right word would be, delineate kind of the components of compassion from those perspectives, from those individuals specifically. So again, it's important to remember that this is anchored within healthcare, but it's kind of traverses now across different settings. So we've validated or assessed the transferability of that model in outpatient, inpatient settings, acute care, um, long-term care, home care, to sort of make sure like are cancer patients kind of understandings of compassion different than a cardiology patient? And we've largely found that while there is some variance, not only between different patient groups, but between individual to individual in terms of both their experiences, how they personally experience compassion, and also how healthcare providers express compassion. We kind of have these kind of key domains and components that make up the model. And basically, in a nutshell, that is virtuous response, which really involves kind of the qualities, the noble qualities of healthcare providers in terms of what they bring to the game, in terms of what they sort of bring within them before even walking down the hall and visiting a patient. As well as sort of their intentions in using those virtues, those good and noble qualities in that interaction. There's this idea of relational communicating, so communicating from a place of shared humanity, which is very different than typical clinical communication, which is often sort of like, I am the expert and I will try and communicate what I need to tell you in 2 minutes or less so that you understand it and that I'm out the door sort of seeing the next patient that needs to see me. Seeking to understand is the other kind of pillar, and that involves two things primarily: seeking to understand who that person is as a unique individual, and seeking to understand their unique needs, and then attending to needs, which is really sort of the backbone, which is really around action. Like these are behaviors and things that healthcare providers do to alleviate suffering. So that model, I think, has really been sort of the guide for all of the work that we have done. And the definition that comes out of that for us is compassion is a virtuous response that seeks to address the suffering and needs of a person through relational understanding and action. And really, I think at the end of the day, um, I'm not a cook, but you know, when you apparently when you make like a reduction sauce, you sort of just boil everything down. Um, that would kind of be what I have to account for in terms of a conceptual definition, which is a little bit
okay.
depressing, to be honest with you.
Oh,
But in all
tasty
honesty,
though. Very, very tasty.
I think it could be tasty.
Yeah.
The models that we develop are also aesthetically pleasing. They're presented well. They plate well, Stan, as well.
Okay.
So we have that as well. But so really, to answer your question, that model has been vetted through so many different patient populations, as well as cultural groups. And so that's kind of our blueprint, the DNA, which
Mm.
then subsequently um, we use to develop the measure that we develop, the SEQ, based on those domains and through a very rigorous process of measure development.
Mm.
So we sort of mapped it out, blueprinted it, if you will, and then developed the measure after doing another systematic review, looking at sort of the limitations of existing compassion measures. And so knowing that we then went and developed this SEQ that I'm talking about.
Yeah. Yeah, no, that really captures something, very it captures the idea sort of beautifully, really. There's a kind of an intentional piece. The health provider kind of almost creates an intention or an attitude with which they then, perhaps walk into the room. Then there's a kind of a relationship building piece trying to kind of create that context. Then there's a sort of an understanding, a listening to understand, and from there, with greater understanding comes greater helpfulness, I guess. And then we move to the fourth bit, which is the taking action, and sort of
Yeah.
these kind of key sort of pieces. Those are the sort of the health practitioner side of it. Is there something, because you sort of alluded to the giver and the receiver, that there's something in the person that's perhaps offering the compassion, providing the
Yeah.
compassion. What about the receiver end? Can you sort of just tell us a bit more about some of the patient-oriented research
Yeah.
there?
So that model that I was speaking of was actually first developed by patients, and then
Ah,
we kind of looked at the mirror side, the other side of the bedside, if you will, and went back to healthcare providers and said, well, it's great that patients tell us they can like intuitively feel compassion coming from their healthcare providers, and that you as a healthcare provider are doing certain things that they see as compassion. But you kind of need to verify like with the person to make sure like is that in fact what is going on there? But to answer your question, I mean, there's so many people that I've talked to and my team has talked to over the years, but um, I'm amazed in some ways that a lot of these folks felt that they could intuitively feel compassion. And I have no idea how that happened. I think there's probably a lot of other processes that are also going on, namely in terms of like, nonverbal cues and eye contact and certain gestures that are beyond kind of my area of expertise. But I remember vividly, a patient saying to me, like, you could blindfold me and bring in like five healthcare providers, and I'm, they could talk to me, they'd have to do something, but I could, by their tone of voice, and sort of the sense of their genuineness, I could pick out who would be compassionate. Now, we've never run that in a clinical trial. It'd be a wicked trial to do, but blinding people in a different sense. But I think that's the thing that amazes me. Again, there are certain actions and things that are done, but it's not so much the actions themselves. It's again more around the way in which that care is given. And
mm.
I mean, I know you come from sort of I think you come from a counseling psychology background. Is that right? I mean, you
Yes.
count, yeah. And
Yeah.
and you can you can jump in and correct me. But, I think from my own experience and just sort of taking care of myself and seeing a therapist when I need to from time to time, or, just even looking at some of the research that has been conducted, is when you look at clients or patients, and you sort of ask them, like, what makes a good psychotherapist? For them, it's sort of all about the therapeutic relationship, and they wouldn't you necessarily use those terms, but they're like, I can just I just get a good sense that like Stan really seems to understand me. And I had this other person who kind of pretended that they cared for me, but I could tell that they didn't seem to. So again, I think those things for me, they can be packaged in different ways and have been in terms of there's some elements of empathy that's there. There's some, elements of just the therapeutic relationship. They've been coined and termed in different ways. But I think when you put all of those things together, and certainly the model illustrates that, what you get that comes out of the oven, to use our analogy, the pie,
Yes.
is compassion. It's there's some apple in there, there's some cinnamon, but I think when you bundle all of that together, that is what patients would describe as compassion. And obviously, there's a few things that maybe don't fit. I don't want it to sound like compassion as this panacea that just sort of like you can boil everything into. But I think you get the sense of what I'm
Yeah.
talking about.
Mm.
And I think the same is true when you look at different wisdom traditions, whether it's Buddhism, Christianity, Hindu, whatever tradition you look at. And we also looked at this, but when you look at all of these traditions, there's great differences in terms of dogma and practice, but they tend to all agree that sort of the ultimate outcome or the ultimate marker of being a true Buddhist, a true Christian, a true human being, just in general, is compassion. It's not about, a personal relationship necessarily with a particular deity. That seems to be important, but it's not about like just me. It's about extending, you know, I think spirituality in action in some ways might be another way of thinking about compassion is the doing part of that. So I think all of those different kind of disciplinary, but also worldviews for me kind of really culminated uh, in this term compassion. And I think the model that we developed with the help of patients and healthcare providers and family members, I think is a further reflection of that, what I would call a holistic sort of perspective of what compassion is.
Mm. And the whole is greater than the sum of its parts in a way, isn't it? That's I think what you're reflecting there is that you sort of have identified these ingredients in a way, but even that doesn't quite capture what it feels like, the felt sense of it when someone walks in the room and you can sense it almost immediately that this person is very genuine in their care and concern, and there's a warmth and a friendliness. And often maybe it does, if we're being reductionistic, maybe it comes through the tone of voice or the eye contact, and but the whole is greater than the sum of the parts, and so it's a
Yeah.
hard one to fully pin down, and yet humans tend to know it when they feel it too. It's sort of
And
interesting.
I think that's what maybe is a better way of describing what I was trying to articulate is I also remember interviewing a lady who said to me, because we asked them as well, do you think you can train compassion? Like, can you learn compassion? And we asked healthcare providers, but we also asked patients this. And I remember a patient saying to me, she said, I think you can, but I think you're always going to start with sort of the baseline compassion ability that person brings with them. And you can build upon that, but different healthcare providers maybe start at different points. But I remember her saying, she said, I don't know if they teach this in medical school, but I had a medical resident come by and he sat down, changed his tone of voice, and started speaking in a slow and methodical kind of way. And she said, I don't know if that's what they teach them compassion is, but if it is, it annoys me to know,
Yes.
endlessly. And so again, I think to your point, and I think this is the challenge as well, is you could take, all of those aspects of the model, or you could take, the work of other people that have really sort of dialed into tonal elements and sort of posturing, elements related to compassion. And at the end of the day, it might just be apple, cinnamon, and pastry, because the way in which it's delivered seems to be such an important aspect of it. And so I sometimes worry that, in sort of mapping out not only those domains, but underneath it are sort of themes and granular like behaviors, like sitting versus standing at the bedside, um, you know, having eye contact as appropriate, supportive touch, that we don't just create sort of like robots that kind of come in and turn their head to a 95 degree and start talking in a slow, methodical way and sort of reaching out and touching us on the shoulder in a kind of creepy, feigned, inauthentic kind of a way. So I think that's kind of one of the challenges of how do we do this, whether we're our training is sort of more in a contemplative practice or looking at sort of behaviors and skills, I think we can pretend, and I don't think we're providing compassion because I'm not convinced compassion can be contrived. I think it's something else. Um, but I think we have
Mm.
to be careful, um, because to your point, it is not just about the parts, or the whole, I should say. It is about the parts, but I think we have to be careful not to sort of slice it down too much.
Yeah.
And certainly in some situations there, you know, we're not suggesting that you have to do all of these things all of the time in order to kind of get compassion. Um, I think there's certain situations where a person is in an a medical emergency, I should say, and they might not need the relational communicating piece, like as they're sort of bleeding out. They
Mm.
need like the action component of compassion and somebody to do something about it. And so I think those elements get woven into subsequent conversations, and they sometimes it's one more than the other, but I think all cylinders, would be sort of firing, if you will, over the course of that sort of therapeutic relationship.
Mm. And it takes wisdom, doesn't it, to really be able to tell the difference of what
Absolutely.
matters when and those sorts of things. And I've always felt that you can't quite pretend compassion, or it becomes a bit too contrived, but you can practice it, especially if there's a genuineness in the intention behind the practice, sort of thing. And so if people are sort of practicing to reach out and to offer physical touch, and it's obviously not quite what they're used to, but you can somehow still sense the genuineness behind it, then that's better
Yeah,
than the person who's just doing it to sort of, kind of look like they're being compassionate, even though they're not actually feeling
yeah,
it or something like that.
yeah. And I think to be fair, like some, you know, uh, physicians that I've worked with, they're just like, I know what you're saying, but can you just give me kind of like the five things that I absolutely need to do because I struggle in this area. And so I think we need to have some openness to, some people might come across as maybe a little bit more mechanical initially because we give them like, yeah,
Mm.
sit down at the bedside, like park your butt down, do that. And they sort of do that in a robotic fashion because we just know that even that one simple action not only conveys compassion, but in trials they actually show that sitting versus standing is perceived by patients as uh, they misperceive, I should say, the amount of time that a healthcare provider is with them, if they're sitting versus standing. So basically, um, same sort of scripted conversation with different different groups of healthcare providers with the same patient, and they perceive that the person sitting is there significantly longer than the person who's there, even though the actual sort of verbatim uh, text is the exact same amount of time. So uh, yeah, I think we need to be open that not everybody is able or as able as somebody else, and so maybe we do have to provide some provision for like here's a sort of a compassion safety kit, if you will. Like do these three things. I don't know. I just
Yeah.
thought of that.
It's at least a way to sort of, yeah, ease people in, ease the physician or the health practitioner. And it reminds me a little bit of the TV show The Good Doctor, which I've sort of watched recently, and that's a young doctor who's a genius, but also, isn't great at the social emotional side. And so his
Yeah,
his journey across the series is to gradually develop, those various kind of relational skills, and he sort of mucks it up sometimes, and then he kind of recovers himself, and you can sort of see his growth arc
yeah,
across the series. Um,
yeah,
I recently was talking to someone who is sort of recovering from breast cancer, and has had a successful treatment, and she was reflecting not so much on health practitioners, I suppose. It's not quite in that area, but she was reflecting on the way that friends were trying to be helpful. And one of her points was that some people kind of showed up and sort of nailed it, and other people, I don't know, just were sort of came up with things that just were misguided or made her feel sort of more awkward or worse, or, so I suspect in the action piece of it as well, there's sort of, there's wisdom there too, isn't there, in terms of what is
Yeah.
it that's
Yeah.
actually most helpful here?
Yeah. And I think you've used the word wisdom a couple of times, and
Yeah.
that was actually one of the 10 kind of key virtues that was
Ah.
associated with compassion in that virtuous response domain, because it's not just sort of a shotgun approach of throwing yourself into the burning house. There needs to be some discernment, not only how can I be the most helpful here, but how, who is this person and how might they be different than the last person or client or patient that I just saw, who might have the exact same diagnosis and symptoms, but they don't need what that person needs. And so I think that's why, like, I did sort of present sort of that model sequentially as sort of like walking down the hallway with the virtues, of your heart, those noble qualities, and setting an intention, going into that relational space and communicating and seeking to understand and then action. But in all honesty, is sort of there's an ebb and flow back and forward between all of these different elements, kind of in tandem. Um, because to your point about the individual who found some things helpful and some things not, I think that's one of the areas of growth when it comes to our work in compassion is it's not a one size sort of fits all. And I think that's why that seeking to understand element is so important, because it's about me kind of calibrating what I think compassion is, to that person, and not just assuming, um, that the actions that I think are important are actually what that person thinks is important. And so I think, within healthcare, um, sometimes hugs equal compassion, like that's what I think a lot of people think. And for many patients, I think they receive that as compassionate, perhaps. But for some people, that is the opposite, perhaps, of what compassion is. If they have a, historical trauma, they've, have a history of physical abuse, they come from a culture where I, as a cisgender male, it's inappropriate for me to be hugging, a Shiite Muslim woman, for example. So I think we need to, um, yeah, I've heard terminology such as, I don't know if it's stupid compassion or idiot compassion, but I've heard these sort of phrases, and I don't agree that there is something like that, because I think compassion is anchored in wisdom and it is about seeking to understand. But I think, again, the point that those people are getting at is don't just assume that you know what another person wants or needs or
Mm.
how they receive compassion. Like, you need to attune to who that person is, um, in order to
Mm.
have sort of the most optimal effect, if I can put it that way.
Mm. Yes, I think it's one of your Canadian colleagues who sometimes says things like that, the idiot compassion or toxic compassion. And
Yeah, yeah,
I agree with you. It's sort of missing the point, really, in terms of the virtues that really underpin compassion. And people can certainly make mistakes as they're trying to be
for
helpful, but
sure.
that's there's a kind of um, an iterative process there, isn't there, of trying to sort of just be
Yeah,
aware and to notice the feedback and to be able to review and reflect and try again and refine and all of those kinds of things. One of the things that you've tried to disentangle, I guess, is the empathy, sympathy, compassion kind of dimensions.
yeah.
What are your thoughts with those three?
So again, the research that we conducted was primarily with patients in terms of asking them their perspectives. And so I think it's important to qualify some of that. It was also based, again, on our systematic reviews, looking at those differences. But kind of in a nutshell, what we've discovered from both patients as well as now healthcare providers is sympathy, for whatever reason, like in its original state, it's actually closer to compassion than empathy is, if you look at the actual sort of etymological definitions. But sympathy has sort of fallen on hard times. Patients dislike it. They despise it, I would say, even some of them. I remember one of my most memorable qualitative quotes came from a gentleman who was kind of salt of the earth, and he just sort of said, if you're looking for sympathy, you'll find it between shit and syphilis in the dictionary. And that was sort of
Right.
his. Yeah, that's those are the types of things I remember.
Yes.
But his, he very much, I think, embodied so many of the patients that we've talked to over the years, where sympathy, rightly or wrongly, maybe because of Hallmark cards, I don't know, the sympathy cards section of your local stationery store, but um, they just found it to be a pity-based response that I think is really characterized by a lack of understanding, and really is, I think, makes that individual feel worse and isn't really intended to serve the patient or the recipient, but it's really sort of intended to serve the responders' needs and to keep them intact. And so sympathy was, again, not looked at very, very favorably. Empathy, I think, for me, is sort of a big jump from sympathy. It's much closer cousin, if you will, to compassion. And I think there's empathetic elements that are embedded within compassion, because I think empathy really is this idea of adding in not only a response to suffering, as is true of sympathy, so they share that, but adding in this element of trying to understand, whether that's through cognitive empathy, which is sort of this idea of perspective taking, of really trying to understand what another person is thinking, or, and this is where I think the lines blur a little bit into compassion, this idea of affective empathy, of trying to feel what another person is feeling. But people will tell you, Tanya Singer, for example, is one individual, that there are some important differences. Empathy usually involves feeling with a person, and compassion, I think, does start with that. I don't think compassion is just feeling for, but I think compassion, unlike empathy, evolves into feeling for. And the reason for that is because you kind of get locked in that emotional contagion state when it's just two people resonating like a tuning fork back and forward. And so empathy is a welcomed evolution for patients and healthcare providers from sympathy. And then I think compassion sort of embodies those elements of empathy, but deepens them in a way that it's not just understanding who that person is kind of from a distance, from an arm's length, from the therapeutic armchair or from the other side of the bed rail. It's understanding who that person is as a fellow human being. And so that takes, I think, emotional resonance and takes understanding to a new level. And then obviously, unlike empathy, compassion has this pro-social kind of element that leads to and is marked by action. We can't always deliver on that action all the time, but I think we have to be very, very careful that even our research on compassion doesn't sort of recede back into effective empathy, where it's just about me generating warm and fuzzies and kind of, feeling compassion towards an individual, but then at the end of the day, sort of thinking like, I have better things to do. Uh, I'll
Yeah.
drive on by or whatever it is. So again, I think that has been helpful for us to kind of demarcate and delineate, and
Yeah.
also honor the similarities that I think, are there, for example, between empathy and compassion.
Mm. It's interesting how words and meanings of words evolve, isn't it? Like I think Aristotle might have used the word pity to sort of mean compassion, whereas now pity really no one feels very
Yeah.
comfortable with that as a word, and
Charity.
sympathy.
Yeah.
What
Yeah.
was that? Sorry.
Or charity, like it's charity is sort of one of the cardinal virtues, but the connotation today is like, oh, thanks a lot. You're throwing me some, a couple of bills to sort of alleviate your own guilt, you
Yes,
know.
exactly. The connotation
Yeah.
is the thing that has evolved, isn't it? And sympathy's kind of fallen a bit foul of that too. Like sympathy. Now people hear that word, I guess, and they kind of immediately kind of almost go to pity or something, and they sort of see it as one in the same. Paul Gil, as a psychotherapist, I use compassion focused therapy a lot, and Paul Gilbert sort of would say that sympathy is the sort of the expression of the warmth and concern and feeling moved by what the person goes through. Empathy is sort of the understanding and kind of resonating of their suffering, and compassion is the motivation to kind of well to be sensitive to all of that suffering and to take some sort of action to alleviate it. So he sort of sees the empathy and the sympathy to be important kind of almost competencies behind that compassionate motivation, but not the sort of sympathy that people immediately default to. More um, this kind of feeling moved or touched, and bringing kind of the warmth and care into the sort of the compassion. He would say that empathy sometimes can be used for all sorts of other motivations. Like
Oh,
we might use
yes.
our
Yeah.
empathy to play poker, or something, because we're kind
Oh,
of
yeah.
reading the other person and whatever. What do you think of that in terms of empathy and sympathy as perhaps competencies that we might bring to that compassionate motivation?
Well, I think just to your last point, I can't remember who it was, but I think they found, and I'm not up to speed on this, so don't quote me on this, but that I think even sociopaths have sort of empathetic, high empathetic ability,
Mm,
in terms of being able to use that, to resonate with a person and understand what they're feeling, to be able to use that for their own advantage.
mm,
And so I think it's important. There's no value, I think, in sort of navel gazing and semantics on the one hand, but
yeah,
I do think it's important to look at these things, in a sort of a scientific fashion to really understand what's going on there. So I'm not. Yeah, I'm not a huge fan of sympathy. I understand other people sort of, it's really, I think, the vehicle, as I understand it, from what you said, from sort of the oven out of which that initial response, spark plug, if you will, of compassion comes from. Um, and I think for us, it's probably that's the virtuous response aspect, and in some ways, maybe it's the
yeah.
same thing. I mean, I think in some ways we're probably talking about the same
I
thing, but
think
I
so.
think for me, it's the challenge is in we may never use that terminology for patients or clients.
That's right.
Um, so they might never know that is what is being invoked. But I think we have the responsibility at the same time to sort of recognize that terms do morph and evolve, and they are experienced by individuals in a certain way. And so in clinical care, I think it's really, really important for us to, if we know that patients prefer compassion, over sympathy and empathy, I think it's important to sort of say, like, okay, well, how are they understanding these things? And we need to make sure that whatever, that I'm not emulating sympathy so much as I am empathy, or emulating empathy and hopefully compassion. So
Yes.
Again, it's a little bit unfortunate, I think, when things come out of sort of fall out of fashion, and you never want to just be kind of impulsive in responding to the sort of the tides of change. But I think the other thing is just the onus of like, okay, what's what's going on here? But like I said, we've done, historical analysis of these differences, and to your point, with Socrates, like sympathy is actually a little bit closer of a cousin historically than
Yes,
empathy is.
linguistically, sort of. Yeah,
Yeah, but that's
yeah.
a conversation for another day, probably.
It's really great because yeah, we don't sort of say as healthcare providers, okay, I'm going to deploy my sympathy now, so we're not using the word with the with the patient. What we're
Yeah.
really trying to work out is um, what would feel like this sort of unwanted construct for the patient. What would sympathy feel like for them that they wouldn't want? And let's try to move away from that. And what would empathy and compassion feel like? And let's try and move towards that, putting aside the words and so on, really trying to think what can we learn from that sort of aversion that people feel to something that might be called sympathy or pity or those sorts of things. We've talked a fair bit about compassion from the health practitioner to the patient, but you've looked a fair bit too into compassion fatigue and self-compassion and where that might fit in. Can you sort of touch on that piece of your work?
Yeah, so I think we were interested in not only doing systematic reviews on sort of compassion in a more kind of gestalt, larger aspect, but also looking at some of those sort of subsidiary concepts, such as self-compassion and such as compassion fatigue. And so am by no means an expert in terms of those fields, but the reviews that we did, and this is probably 5 or 6 years ago, and the field has changed certainly in terms of, I think, self-compassion, not so much in terms of compassion fatigue, was, at that point, there wasn't a huge amount of evidence demonstrating that self-compassion, as we understand it and has been articulated, uh, shows in a scientific way an improvement in healthcare provider well-being or in compassion to others. And again, I think the important piece is to recognize that um, just because we're not able at this point to sort of, or at that point to show those differences doesn't mean that it's not doing something. And I think we're now at a point where it probably is. There is evidence, I would argue, that it does improve those aspects. But I also think and remember a recent study by I think it was by an individual's last name was Cha. Kirby was on that one as well, and Considine as
Oh,
well.
yes.
And what they found was self-compassion, sort of in and of itself, did seem to improve compassion to others. However, the thing we have to realize is the measures that are used in these studies, the measures that we typically use, are self-assessments by healthcare providers. And so that's a limitation because I can say I'm more compassionate to other people as a result of this, but I think the proof is in the pudding, as they say, in terms of does it trickle down to actual recipients' experiences.
Mm.
Um, and if I'm remembering and not bastardizing those results, I think the key thing was the values that individuals bring with them are the mediators of whether self-compassion actually translates to greater compassion for others. And I think it was sort of this self-transcendent value domain that is actually sort of the pivotal piece. So, anyways, a long-winded way to say, um, things have evolved on that front. But I think an easier thing to speak to is sort of compassion fatigue, which, yeah, our standpoint on that is there really is, and others have confirmed this since our reviews. Um, there is no evidence to suggest that compassion in and of itself is tiring, fatigue inducing. And if anything, there's actually probably more evidence to actually suggest the inverse, that when therapists, when healthcare providers are not only supported, but are able to provide compassion to other people. They work in environments where that is not only allowed, but supported and encouraged. It actually has a sustaining effect in terms of their well-being. And so again, I think what we're really talking about and what we discovered in our reviews was um, compassion fatigue, I think more correctly, is really looking at occupational stress and burnout. And what happened was, and this happens all the time, whether we're looking at self-confidence or other things, or we're looking at burnout and occupational stress, is somewhere along the line, somebody decides, you know what, occupational stress just doesn't do it quite right. We need something, and this came out of actually the nursing literature that is specific to kind of the burnout that nurses feel. And we're going to call this compassion fatigue because it just sounds a little bit more sexy. And again, I don't want to unnecessarily sort of perseverate, again, to use that word, on words and slicing, hairs and things like that. But I think it has some pretty big ramifications because when you attach a label to that, it implies that we have this finite resource called compassion, and it's in a tank somewhere, a reservoir within us, and it just kind of gets burnt out. And I think, again, I'm not suggesting in the least bit that people don't get burnt out, but it doesn't have to do with compassion. It has to do with the workplace environments that we work in, and probably a fair amount of moral distress amongst healthcare providers, particularly, I'm thinking of, during the pandemic, where they wanted to provide compassion, but they were unable to do so. And that, I think, is really what we're talking about, is moral distress. And um, yeah, so those are sort of subsidiary areas that we looked at in a critical, I think, academic kind of a way,
Mm.
to really kind of understand what's going on there. So we've done, I don't know, probably 10 or 12 systematic reviews. And as I'm saying this, you can see the expression on my face. I might actually have to change my opinion about compassion fatigue because all of this has tired me out. But I don't think it's the
Yeah.
compassion. I think it's just being stupid and doing too many systematic reviews and research projects.
Yeah. No, I'm really on board with what you're sort of saying there, to be honest. I too feel like compassion fatigue is a bit of a misnomer. I know there's a history to that as a term, and I sort of get it, I guess. Figley was talking about,
Yeah.
sort of fatigue in the war zone type of thing, wasn't he? That the people who were
Yep. It was
trying to help.
for people, therapists that were working with people with PTSD coming back from the war.
Yes, and
Yeah.
and so I think he almost was riffing off the old term battle fatigue in a way, as which was sort of a precursor to PTSD, and so he was sort of like compassion fatigue is what happens to the helper and so on. But in some ways, it's sort of more compassion prestige, like if we're able to be compassionate and kind of cultivate that, especially in a broader system of compassion that supports all of that, then it's very sort of self-sustainable, and there's a twofold benefit, as Matthew Ricard might say, for the compassionate person as well. And yeah, sort of burnout or occupational stress feels, in some ways, the thing that I balk at is that compassion fatigue almost puts the onus back on the health professional, and sort of
Exactly.
it sort of runs the risk of almost a blaming thing, because
It totally does.
it's not the system, it's your compassion sort of a thing. And so that's when really often it's the system or context or other factors that get in the way of one or other of your elements of the model. And often it's when something gets in the way of the action, because then you're feeling the empathy and you're resonating and you're sensitive to the person suffering, but you can't do anything. You're sort of blocked with your compassionate
Yeah.
action, and that kind of is tough.
And I think it does. I mean, healthcare providers, I think, love and hate that terminology because it does implicate them, that there's something deficient in them, that they're getting, you know, this special kind of burnout called compassion fatigue. And it takes, it takes the responsibility away from the system, I should say. And I think the same is true, in terms of self-compassion practices. Like, I think those things are hugely, hugely important. But the answer to, a lack of compassion is, well, you should just be, you as a healthcare provider should just be doing like a little bit more
More.
self-compassion, and you should be more resilient. And like healthcare providers over COVID times and the pandemic, they hated that, because it just completely dishonored their experience of what is going on.
Mm.
And I think, again, it allows the bigger issues that are at play in terms of organizational compassion or a lack thereof to kind of be let off the hook. And I think that's where I see compassion research needing to evolve into is we've kind of figured out kind of effective, compassion and, cultivating compassionate emotions, virtues, practices, those sort of things. Now, I think with our work and others, it's sort of like, let's get that, get off of the meditation pillow, get out of the pew, get out of the nursing station, and here are some actions and behaviors. But now I think we need to actually kind of move beyond that and like, okay, well, now we know that most healthcare providers actually inherently want to provide compassion. Many of them, the reasons they get into a healthcare career is not just to make, money. It's often for altruistic reasons. But what they end up sort of meeting when they show up at work or a week thereafter is, a system that is anti-compassionate, I would say, in many ways, in policies and procedures and unconscious bias and systematic racism that prevents these sort of individuals from doing what they signed up for.
Mm. You mentioned Nathan Considine before, and Tony Fernando was working. They were working together on a kind of a model that was really bringing in some of those system factors and contextual factors and various
Yeah.
other elements to it, trying to, as you say, kind of go beyond just the health practitioner and so on. Mind you, and this is just the last little bit I wanted to probably just quickly ask you about, because I don't want to take up too much of your time or too much more of your time. But I was very kind of excited to see that just this month you've published a paper. It's the initial validation of an evidence-informed, competency-based applied compassion training, ENACT program, a multi-method study. And so
Yeah.
I wondered whether, could you just give us sort of like maybe some highlights there, perhaps, just in terms of that study trying to, yeah, sort of help help health practitioners cultivate compassion.
Yeah. So again, I'm kind of a very sequential thinker, and so you conceptualize and develop the foundation, develop a measure. Now we're building an educational intervention. And again, to our previous point, it's not just an intervention. It is training for healthcare providers, but it's actually training that we also partner with healthcare organizations and senior leaders. And so they need to kind of be signed up for this and agree to what we deliver. And just as an example, one of the things that we deliver is one exercise is this idea of sort of being a compassion consultant within your organization. And so we get healthcare providers to sort of come up with a list of recommendations that they think would make their organization or their workplace more compassionate. And the idea is that, to have the ENACT program, you have to agree as a senior leader not to take all 30 of those recommendations, but you need to choose 3 of them. And you need to enact them,
Ah,
over the next 3 months or year or whatever time frame. Because the reason is we know when it comes to compassion training of any shape or form, the problem is sustainability. You can have people in a space, a meditation space for a day, and they'll come out of there feeling quite good about things. But a few days later, it sort of dissipates. And in the same way, we can teach people skills and communication skills and behaviors. But if the organization's not on board, then it doesn't work. So it's very much an integrated program. It will be offered online. So we are going to be taping some online modules, which will be accredited here in Canada with the Royal College, as well as endorsed by other organizations. And yeah, so the initial study was kind of taking it for a bit of a test ride and making sure like everything's holding together correctly. Prior to this, we did a ton of sort of beta testing, if you will, with patients, families, healthcare providers to make sure we got it right. We had a number of studies. We actually sat down and talked to the likes of Paul Gilbert, Kristen Neff, there was others, Doty, and we sort of said,
Oh, yes.
you guys are sort of the preeminent leaders when it comes to compassion education. What's the inside scoop here? What would you do differently? What do you think needs to be done, to make things more sustainable? And so we did all of this foreground work to kind of make sure we got it right. And so that's where the ENACT program kind of came from. And just in terms of the initial validation work, we were actually able to demonstrate in a small sample, so that needs to be, I think, kept in awareness, a statistically significant increase in compassion competence pre and post training. We're also going to use the SEQ, the compassion measure that we developed for patients, as an outcome measure. And we've been measuring it now for 9 months. At the end of, like in 4 days, literally, is the end of that data collection period. And the reason we're actually asking about patients' experiences of compassion is because we believe that if a compassionate intervention actually is going to have an effect, it needs to trickle down to the bedside. Whether we get, a result from that, who knows? It's to be determined, but it looks pretty promising as we're looking at it. So, yeah, it's been a great experience, and I'm always amazed at the stories, both the highlights but incredible lowlights that healthcare providers bring with them to our training programs. It's a tough, tough world to work in out there. And I'm also always amazed at some of the suggestions and those recommendations, for example, that they come up with. One group said, our biggest recommendation is a bring your boss to work day. Like bring the senior executive down from the cornered office and let them shadow us, because it would be good for them to understand what it's like. So yeah, I've probably done a great disservice to what has amounted to 4 years of research, but I think that in a nutshell is what we're looking at.
Yeah, no, I'm sorry not to give you a bit more time on that one, but I will definitely connect or provide the link to some of the summary, or to the paper itself, but also to you have a summary of the results on your website. I'll include a link to that Compassion Research Lab website. There's also a website for the measure as well, and so
Yep.
we'll sort of include all of those measures.
Great, thank you.
I've been so fortunate to interview several of the greats: Gilbert, Neff, Doty, Sinclair. Like I'm really I'm having a good time getting to talk to everyone, and considering this massive body of research that you've toiled away at for such a long time, you do still look very youthful. So that's
Well, if I had a high resolution camera, you'd see a few gray hairs on this head, Stan.
okay.
But I appreciate your kindness. We'll call it that.
Yeah, let's call it that. Let's call it that. But no, I will include all of those various links, and people can kind of check out your work further. But Professor Shane Sinclair, yes, thank you very much for coming and speaking with me on Compassion in a T-shirt.
Yeah, and thanks for having me, and thank you for this work. I've followed your work quite enthusiastically, and I think getting it out to the masses is something that we need to do better as researchers as well as clinicians. So thank you.
Thank you very much.